All right, good afternoon, everyone. Today I'll be talking about the implementation of a stakeholder-centered ethical data use practices in Beehive, which is an e-health technology that promotes data-driven care in the California Early Psychosis Intervention Network. First, I want to acknowledge that there are 33 authors on this presentation alone, with many more collaborators on the EpiCal project. So here are the key faculty on the EpiCal project. It's a collaboration between the University of California, Davis, the University of California, San Francisco, and the University of California, San Diego. I want to give a particular shout out to Tara Needham. Do I have a laser? Let's see. Nope, doesn't work. She's there in the middle. She's our fearless leader and tireless visionary. And I also want to highlight that one of our collaborators on the slide here, Dan Shapiro, is here at this meeting today. He's sitting in the second row. So if you have questions about the project, you can also ask him. And then we also have a fantastic team of staff, postdocs, research assistants shown here. I want to give a shout out to Dr. Sabrina Arashevsky, Kathleen Nye, and Chris Hakasui. All three of them were really instrumental in collecting the data that I'm going to be presenting to you today. And Dr. Arashevsky has a poster during the poster session tomorrow lunchtime on another aspect of this project. So I really encourage you to go there. Couldn't have done this work without them. Allora. Last bit of admin before I continue. I need to let you know that both myself and Dr. Tara Needham have ownership interest in a company called Safari Health. It's a digital health company, but Safari Health is independent of EpiCal and it's independent of any of the associated grants and not related to the work that I'm talking about here today. Okay, now for the content. So I want to set the stage by orienting you to the California Early Psychosis Intervention Network, or EpiCal. It is funded by the NIH, a collection of California counties through a particular funding mechanism in California called Prop 63, as well as a nonprofit company called One Mind. They've presented at this conference in the past, so hopefully some people are familiar. What EpiCal does is it links multiple early psychosis programs in a learning healthcare network across California. So you can see here the highlighted counties are the ones that are involved in EpiCal. Yellow or blue simply indicates the funding source that they have money from. What we've done is we've used a stakeholder-designed e-health platform called Beehive to collect outcomes and clinical care data. And what Beehive does is it feeds the data back to clinics to support treatment decision-making and program evaluation. So what is this Beehive that I'm talking about? Well, it's an e-health software that we developed, so it comes straight out of UC Davis. It includes tablet and web-based outcomes data collection, so our patients and families are completing surveys on a tablet or on a web platform. And then it has a web-based dashboard that summarizes the clinical outcomes data at an individual level, the clinic level, and at the whole network level. Importantly, Beehive and the associated outcomes measures were developed in collaboration with providers, clients, and their families through a series of focus groups. So this is truly a consumer-driven or stakeholder-driven process, and we're really, really proud of it. We've conducted hundreds of focus groups with our stakeholders to date, and it's a beautiful thing that we've made. Unfortunately, I don't have time to give you a full tour of Beehive. I had hoped to show you a video, but unfortunately I need to stay within my 15 minutes. So I'm just showing you here a screenshot of a client's dashboard and what it looks like. So you can see that there's longitudinal data on a particular symptom measure shown here. This is the modified Colorado symptom inventory. The patient scores are in the blue bars, and the comparative scores across the network here are in the purple bars. You can see a breakdown of the individual survey items on the left. You've got important information about the client themselves, including things like diagnosis, pronouns, birthday, etc. And then some summaries around service utilization, how many groups they've been to, how often have they seen their psychiatrist. And this dashboard was designed to be looked at with the patient and the family members in the room. And we also collect data about how useful this dashboard is when it comes to making treatment decisions. If you're interested in seeing more of Beehive, come find me afterwards and I can give you a live demonstration. Honestly, I'm very, very proud of this work that our group has done. So how does Beehive facilitate the EpiCal learning healthcare system? Well, in a learning healthcare system, information is flowing to and from service users to the clinics and then into the research team, who then feed that information back into the clinics and in turn use that to support treatment decisions. And it goes on ad infinitum. And this is how our healthcare system and the care specifically for young people experiencing psychosis can get better through data. The problem, however, is that a learning healthcare network relies on clients or patients choosing to share their data with EpiCal and the NIH researchers. Without the data, we can't really do anything. Here's the second part of the problem. Typical e-health software has very long end-user license agreements, or EULAs. This is the terms and agreements that you sign anytime you update an app. For those of you that downloaded the SIRS conference app, you had to accept terms and agreements. Anybody who's updated their iTunes recently, you had to accept a terms and agreement. Raise your hand if you've ever read it. One person. 2 people. This is good. These EULAs are very long, they're replete with legal terms, and there's minimal transparency about how much control you as the user have over your data. What this does in a learning healthcare system is it limits willingness to share data and diminishes users' agency over their own data. So the solution, which is the study I'm talking about today, is to develop an accessible, transparent, and flexible EULA shaped by stakeholder input as part of the Beehive implementation process in EpiCal. And the goal here is to promote and adhere to ethical data use with a focus on the user ownership of the data. So Beehive doesn't own the data, UC Davis doesn't own the data, the person who gave it to us does. So in order to do this study in line with the stakeholder-driven purpose, we conducted focus groups with 3 types of community members: clinic staff and providers, so doctors, psychiatrists, counselors, supported education employment specialists, clients receiving services, and family members and support people. There are 5 stages to the study. First, we conducted a series of focus groups to understand people's understanding of data sharing and their preferences. We then used that information to develop the EULA materials. We then took it back to the focus groups to get their feedback on it. We updated the materials based on their suggestions, and then we launched Beehive in over 10 counties across California and took data on how many people are sharing with us. So let's talk about part 1, the phase 1 focus groups. In these, we discussed participants' understanding and perspectives on data sharing in general, changing their sharing options. So this includes this concept of a living informed consent, the idea that you can change your mind. Sharing different types of data, so identifiable data versus de-identified data, and sharing data at different levels, individual versus group. During these focus groups, all participants stated that they are willing to share their data if there's a clear benefit for themselves or for other people's care. We also realized that people had a really good understanding of the current laws protecting health information in the United States right now. People were very clear that they do not want to share identifiable data. They want to share de-identified data. And more importantly, they are not interested in sharing data with commercial entities. And this is a really important point for those of you in this room who might be working with a company and using their technology. Our clients don't want their data to be monetized. Factors that increase sharing data for research purposes included trust, familiarity, and rapport with their clinic, user control over the data, so this idea of their right to be deleted or this living informed consent, clarity around what the protections are in the technology itself, and then transparency around the sharing options, specifically this idea of opting in to share rather than having to opt out. So we took these themes from the focus groups to develop the Beehive EULA. And in order to address the themes of trust, transparency, and clarity, we produced an informational animated whiteboard video explaining EpiCal, what Beehive is, key terms regarding data types, and sharing options, as well as the purpose of sharing the data. To provide user control over their data, we designed an opt-in checkbox EULA for Beehive users to choose how they wanted to share their data and at what level. And we incorporated methods for reviewing and updating their data sharing preferences and requesting data deletion into Beehive itself, so they can do everything in this one place. So I'm going to show you a portion of this informational video. I can't show you the whole thing because it's 7 minutes long, but it is available on our website, and I'm happy to share that link for folks afterwards. What I did is I put together a little highlights reel for you, and fingers crossed the technology is going to work and you're going to be able to hear it.
Beehive is an application used by your clinic to help you track your recovery journey. This video will describe how Beehive works and the terms and conditions of using Beehive as part of your care. Beehive was built by researchers at UC Davis to support the California Learning Healthcare Network for early psychosis programs. This is also known as EpiCal. Your clinic is part of EpiCal. All EpiCal clinics are using Beehive to improve care and collect information about which treatments work best. You have the choice to allow Beehive to share your de-identified data with researchers outside of your clinic. Choosing to share de-identified data protects your identity while allowing researchers to understand how individual characteristics like age and where you live impact recovery. Sharing my data with UC Davis. You can opt into sharing your de-identified data with UC Davis to use for research purposes. If you choose to share your de-identified data for research purposes, it will be exported from Beehive and stored on secure research servers. Sharing my data with the National Institute of Health, or NIH. EpiCal is part of a national network of early psychosis programs funded by the NIH. Westat, an employee-owned research corporation, was chosen by the NIH to store the data for this network. You can give permission to allow UC Davis to share your de-identified data with Westat and the NIH. If you give permission to allow UC Davis to share your de-identified data with Westat and the NIH, it will be exported from Beehive and stored on secure research servers hosted by Westat and controlled by the NIH. Other researchers across the world may request access to use this de-identified data for their research, which can help improve care for other individuals with psychosis. Choosing to use Beehive as part of your care will help your clinician to understand you and your goals better. Choosing to share your de-identified data with UC Davis researchers will help clinics across California understand what's important to their clients and their recovery. Choosing to share your de-identified data with the NIH will help researchers across the country provide high-quality, recovery-oriented, and consumer-driven early psychosis care. You don't have to use Beehive if you don't want to. You can still receive your standard clinical care without it. This is your data and your recovery journey. We hope you choose Beehive to go on this journey with you.
Okay, so that's just some highlights from the video, and they see the video at the very first step of registering in Beehive. And once they've seen it, they have the opportunity then to agree to the terms and conditions. So the next few slides that I'm going to show you are screenshots from that terms and conditions page where they check some boxes that we developed initially in this study. So don't worry too much about reading the text. The most important thing for you to see here is that these are the required terms of agreement in order to use Beehive just as part of your clinical care. Forget about the research. This is just, I'm using this in my clinic. They have to acknowledge that they understand that the application is for data collection only and not for emergency treatment. They have to acknowledge that they understand that their clinic will see their identifiable data. So there's a relationship between Beehive and their clinic. And they have to acknowledge that they understand that the team at UC Davis that developed Beehive will have access to their de-identified data as part of tech support. So if somebody's having a problem logging in or there's some bug in the dashboard, our tech team needs to be able to handle that. None of this is for research purposes. This is just for standard care. Next, they get to see their optional terms of agreement for choosing to share their data. And there's two levels here. They can choose to share their data for research purposes with the UC Davis team, and then they can choose to share their data with the NIH. And both of these checkboxes are optional. And then finally, they have to acknowledge that they understand that they can change their data permissions at any time, that they can request the data be deleted, and that they understand that there are limitations to that. So for example, if we submit the data to the NIH, and then this gentleman here in the audience downloads it somewhere in Italy and runs their own study on that data, we no longer have control over that data and cannot delete it from his study. But we can remove it from future data presentations. So folks have to acknowledge that they understand that. We then took these materials back to our focus groups to get their feedback. And overall, the response were positive. Individuals all agreed that the video was a very engaging and informative way of understanding Beehive and its role in the clinic. Clients reported that the video increased their understanding of what Beehive is and how data can help other people. And overall, they liked this checkbox opt-in approach as it presented the data sharing options clearly. They did offer some suggested improvements. Providers suggested that we slow the video down to maximize clarity and comprehension. Clients suggested clarifying the difference between potential benefits of Beehive for their clinical care versus potential benefits of Beehive for research. And clients also suggested clarifying which checkboxes were required versus optional. They pointed out that by having all checkboxes, it was kind of ambiguous where they could leave blank versus not. So we took these suggestions and we made the following improvements. We actually changed the optional checkboxes to a forced choice radio button. So they have a yes radio button and a no radio button. So they have to give an answer, but they can choose which one they want, which provides a clearer presentation of their choice and has more agency. We also clarified benefits of using Beehive as part of standard care versus research in the video itself, and we simplified the terms used and slowed the video down to maximize comprehension, which is why it ended up being about 7.5 minutes long. So we did all this work. We launched Beehive in 10 or more counties. What percentage of our clients are choosing to share their data with UC Davis and with the NIH? And the good news is that over 80% of folks are choosing to share their data for research purposes, both at UC Davis and the NIH. Very small differences between the two, but not significant. One question that I had was whether this number was being skewed by our clinics that are embedded in a research setting. So we have 2 clinics that are closely partnered with researchers. So in those clinics, the clients are really used to researchers coming in and inviting them to participate in studies. So here you can see a breakdown of all the clinics that have implemented Beehive to date. These 2 highlighted in red are clinics that are in an academic research setting. These are our UC Davis clinics. And these clinics highlighted in blue are clinics that are in a community setting. They have no relationship with research. The clients have never done any research before. And as you can see, the agreement rates are pretty comparable across. There's a variation that doesn't seem to be associated with whether you're in a research setting or not. So in summary, eHealth technology, like Beehive, is integral to implementing a learning healthcare network, but it does require open data sharing from users. The work that I've talked about today demonstrates that transparent ethical data use practices are desired by stakeholders and that transparent and clear presentation of the terms of agreement and an opt-in approach result in really high rates of data sharing. So for those of you in the audience who are thinking about implementing some sort of eHealth tool in your clinic or in the work, my advice to you is that if you choose an existing software, carefully read the EULA. Ethical data use practices are not industry standard. Even in Europe with GDPR, companies are usually making money through people's data. Any eHealth tool that shares user data outside of a research or a healthcare purpose really should not be used. And it's important to read the small print here. Next steps for us is to track how many people are actually changing their data permissions. I don't have that data today because no one has done it so far. I'm sure people will change it, and it'll be interesting to see the frequency of that. Thank you for listening. Thank you to our county partners. Thank you to everybody at the NIMH, and thank you to you.
Thank you, Laura, for this very informative and innovative program. Do you have questions? Because my question
Yes, tell me your questions.
Do you know which kind of percent what do you think, which kind of percent will change? What do you think?
I don't know. I think there will be an interaction with where they are in their treatment and symptom severity. So I think that maybe some people at the beginning say, no, I don't want to share my data, and then they feel better and they start to share. And then maybe some people share at the beginning and then they feel worse and they choose not to share. I think it'll be somewhere in the realm of 10 to 15% of people. And they may flip back and forth, right? Yes. So every time they interact with Beehive, they get asked, do you want to update these things? So we might have multiple changes over time. Yeah. It'll be interesting to see, though. Yeah.
Yeah. I think so.
Hello.
Hello.
Thank you very much. It was very interesting to see how difficult it is to set something like this up at the lowest level, getting informed consent. But now, what is your vision about that? What I saw in the first slides, you can collect symptoms, you can collect some characteristics of the patients and how many visits they have and things like that. But what's your vision? How do you want to improve?
How do we want to improve care?
The care and the outcomes of patients.
Yeah, so thank you for prompting me to use my extra slides. So this is a schematic that shows our vision for how data will be used at various different levels in California. So there's the consumer level where they're inputting data and they're getting information back. There's the provider level, which helps us make decisions about what medications we might prescribe or what treatments we might recommend. There's the clinic level, which helps the clinic make determinations about resources. Where do we need to put money? Who do we need to hire to do more of this work? And also using the data to apply for more money. In California, you can get grant funding for your clinic to make it bigger, and the data that Beehive gets can help you get that money. So that's another way of using it. And then at the state level, we'll feed that data up to the state, and this will change policy. So if, for example, our data shows that a particular intervention, let's say substance abuse management module group therapy, is really good at reducing comorbid substance use problems and psychosis, the state might choose to put more money into it, allowing more clinics to provide that treatment. These are the types of data that are collected in Beehive. So we get client surveys, support person surveys. The clinicians also enter information, and we also get service utilization. So all of those can be used to create this really rich picture of early psychosis care in California and what is working versus what is not. So it's really about where are we putting our money? We should be putting our money in things that are working, not in things that are not working. And so that's the vision. The vision is Beehive being a consumer-driven way of directing resources so that our patients are getting better. Thank you. Other questions? Or
I have a question. Oh, sorry.
Oh, I see you. Thank you. So far away.
Thanks so much for this really interesting talk. I really like the approach that you took, the user-centered design protocol. And I was just wondering, because the percentage of people that agree to share their data is really high, so that sounds very promising. Do you have any comparison for programs or to what extent do other programs other people consent to using their data?
Such a good question, thank you. And it is a limitation of this study, and I'll tell you why I don't have this data. This is the first time a digital health technology tool that I'm aware of that is embedded in an early psychosis clinic, and maybe Dr. Fulford will be correcting me in a minute, has actually made it this obvious that you get to choose your data sharing. So I don't have a comparison, because every other tool that we've launched in our clinic has just taken your data. They haven't given you that choice. So I don't know. And it's a really good question. I can tell you that from a research perspective, when we go into the clinic and do kind of informed consent for specific studies, our consent rate is somewhere in the realm of 60%. So 60% of the people in our clinic enroll in other research studies. But those research studies are usually neuroscience, neuroimaging studies, so the benefit is a little further away for the client. And so I would imagine that that's probably a reason why it's a bit lower. Yeah. Good question. I feel like I need sunglasses up here. I should probably, we should move on. Thank you so much.
Thank you very much.